Division of the Ministry of Health in Ontario. In the last number of years, he's been involved in a lot of different types of work, including chronic disease prevention and management strategies, First Nations, guidelines for multiple sclerosis, and among other activities. He's also has won many awards within the public service. He's won the Ministry of Health's ACE Award, the Ministry of Children and Youth Services Pinnacle Award, and 2 Amethyst Awards. I'm not sure what all those are, but obviously you've been a star within the Ontario Public Service. It's great. And he's going to be speaking to us today about health services research and knowledge translation in Ontario. So Michael, welcome. Thanks very much for being able to speak with us.
My pleasure. Thanks, Jerry. Thanks for the invitation, Michelle. So today, my 2 major objectives are to tell you about how the Ministry of Health funds research and how that has just changed from the way we used to do it, and our emerging approach to knowledge translation as we are more of an active funder of research than we were in the past. We now are also trying to create a more active knowledge translation platform. So first of all, that's very, very cool. I love it. So first of all, these are some slides that come from the Transformation Secretariat. So Helen Angus is the Associate Deputy Minister and now acting as the Deputy while the search continues for Saad Rafi's replacement. And the reason I show this is because one key part of knowledge translation is understanding the vocabulary and the environment of which the decision makers reside in, and then it's incumbent upon you as researchers to try and harness that. Your research is only as good as how it fits into the current agenda. So these are slides right from the Transformation Secretariat, so I thought I'd start out with that so that you have some of the dominant themes in which that are really top of mind for the decision makers at the Ontario Ministry of Health right now. So the narrative of the action plan is the need to reduce historical growth of healthcare spending, and it's no surprise to a bunch of people who focus on healthcare effectiveness research and health economics. But the imperative to go from a rate of 6 to 8% down to 1 or 2% is both a mammoth challenge and a huge opportunity. So this drives a lot of thinking right now, and a lot of the initiatives are to try and bend that cost curve into something that will help the province get back into the black eventually. So the other dominant themes are an aging population that is using more health services, not so much because they're aging, but because they're getting more and more chronic disease. So this idea of multimorbidity and high-cost users is a huge dominant theme right now, and how do you address this complex population? And so that's this idea here. So that's where Samir Sinha comes in and his senior strategy report, and some ideas around how to better utilize community-based resources to support this population. And then the Health Links initiative that I'm sure you've all heard about is the relatively few people falling through the cracks. So how do you, again, organize care differently for this really complex population? And then the health promotions, determinants of health. This poor fellow here is overweight and will probably get diabetes and heart disease, and then might end up being one of these people that needs the Health Link eventually. But again, the system could respond more effectively, and a lot of the initiatives put in place by the government right now are to support the reduction of risk factors. So again, I'm not going to dwell on this because this is your bread and butter here, but again, just to show you, this is the thinking right now that's driving a lot of the policy activity right now. Again, the demographics and the increased intensity of spending and healthcare inflation will create this bulge, and that bulge is what we're trying to attenuate right now. So all of these are enormous challenges faced by every healthcare system in the world, and the purpose of the Minister's Action Plan is to start trying to address some of these things so that keeping Ontarians healthy. So smoking legislation, tanning bed legislation, a healthy kids panel to reduce childhood obesity, faster access and stronger links to family health care, and right care, right time, right place. So again, these are the big dot policy items right now. But the question is, how do you do these? These are all enormous challenges. So that's where my role as director of the Planning, Research, and Analysis branch comes in. It's to set up a virtuous cycle where we fund researchers to generate evidence. We build capacity around the areas where we need good people, good science that supports the priorities. We support our colleagues in using that evidence, building it into the policies, better patient outcomes, monitor that, look for gaps, repeat the cycle. So that virtuous cycle is how I think about the Health Services Research Fund. And the Health Services Research Fund is in itself a brand new creation. It was launched in 2012. The first set of program award winners came online in the spring of 13, and it's a sizable transformation because the way the ministry used to fund research was very institutional based, and that it was not unlike a hospital global budget in that you were funded one year and you were funded the next year, and that didn't make for a very transparent or open research fund. And so the Health Services Research Fund is all about finding high impact researchers and the ideas that they have, having a peer reviewed process that is in line with international best practices, and then having those ideas fit into the policy development cycle. So now we are in essence a miniature CIHR. We fund health services research, population health research, so pillars 3 and 4. Ministry of Research Innovation takes care of the first 2 pillars by funding people like OICR and a lot of the activities at Mars. But we're unique in that we are both the funder and end user. Every other province has a research agency which funds research, but is a separate agency. We're ensconced within government. We're part of the bureaucracy, which means that we take our role as funders seriously and try to maximize the return on investment. So if we fund you, we then work with you to figure out what the best knowledge translation plan is to get you in front of the right people and get your work into play. So the Health System Research Fund consists of the program awards, the capacity awards, and specialized research and research health care.
You can use the flickers,
Flicker?
right? Yeah.
All right, I'll go
I
back.
don't know why it didn't work all of a sudden.
That's fine. There are 12 priorities to the research fund, largely informed by Excellent Care for All strategy, Ontario's action plan, and the 2012 budget. Excellent Care for All strategy is a pretty seminal piece of legislation because it actually codifies the idea that the system planning and delivery needs to be based on evidence. So this is actually a law, which I find to be a huge step forward for the Ministry of Health, in that they actually felt the need and the importance to enshrine this idea of evidence-based planning into legislation. So the priorities are the usual suspects of any modern healthcare system: community-based care, healthy living, primary care reform, seniors care, health system performance and sustainability. So when you apply, we ask that you pick one of these categories and align yourself to that. So the program awards are the flagship awards. They're large, $500,000 to $2.5 million a year. All our awards are typically 3 years, which makes it, I guess CIHR's radically changing their funding model, but they're longer than we are. The 3 years fits with sort of the maximum in which we typically can fund anything, any particular program in the ministry. 11 groups were funded. John and Jerry are one of the 11, and McMaster has about half of them, which is amazing. Master fared so well in the last competition that I think it really reflects the emerging, well, maybe not emerging, but offsets the U of T dominance that sometimes happens in competitions like that. So it's wonderful. We have Morris Stewart, Western, Wayne Wary, and Laurentian. So it's a really good, diverse group of people. And I guess we're coming up to the end of the year of year one. So next to come online are the capacity awards. These are smaller grants, 150 to 350 a year. The idea is to focus on new and mid-career scientists who are linked up with a senior scientist. And a big piece of the review was that there was a training environment that was conducive to producing scholars and scientists in these areas of priority, so that the pipeline was always full with ideas and people. And so we got about 100 applications in the fall, enormously strong. We forwarded, I forget the exact number, let's say a third or so, to the external review panel, in which we had people literally from coast to coast, Victoria, from Halifax, coming to Toronto, and we had dozens that were 3.75 and above. We use the same standard scoring criteria, CHR, and we'll hopefully be able to let everybody know soon who are the successful applicants. And it was an enormously strong pool of applications, so it was great to see. The specialized research centers are the last component, and there are 3 of those right now. Institute for Clinical Evaluative Sciences, and I'm sure you all know about what they do and their value, but just briefly, in case you don't, they're the repository of all the provincial health data sets, plus a whole bunch of other data sets, and their strength is that they can link at an individual level so that you can get temporal patterns of utilization and temporal spatial patterns, which is remarkable. And they're starting to get more and more social data sets through their work on the mental health and addiction strategy. So they're slowly becoming more and more like the Manitoba Center, which had really been a social-based research center for, since its inception. Whereas ISIS, Manitoba Center started by sociologists, and ISIS started by internists. So their evolution has followed that, but now they're starting to merge. And I think it's wonderful for Canada that we'll have an Ontario-based center that can do this social type research, as well as the clinical effectiveness research, in which they're so excellent at. So we fund them for infrastructure, because they have a huge infrastructure need with servers and programmers and the like. The Ontario Mental Health Foundation, I didn't know about them before I came into the role, but they are a legislated agency, and they have a few $1 million a year to fund mental health research. And if you don't know about them and you're focused on mental health, you should learn more about what they do and how they fund research, because it's a bit of an unknown resource from my travels. I find often people don't know about them and the opportunities they offer. And they actually do training awards. So those aren't, the ministry doesn't do training awards. We do program-based research. So CHEPA actually still does, with individual capacity development. And then the final piece is the Women's Exchange, which is the follow-up to the ECHO agency, which was the Women's Health Research Agency. And this is led by Paula Rochon at Women's College, and it's to have a center of excellence around women's health research. So this is a diagram that you'll all know. It's cited over 1,000 times. We're in Google Scholar, and then I think if you were to count the number of grants that this was included in, it would probably be up to 50, 60,000 times. It's a well-used diagram. But we're, as the Ministry of Health, we're not so focused on the knowledge translation of any particular program of study as it's used by most researchers. We're looking at it from a meta perspective, because we fund $40 million of research every year. How do you harness that in such a way that it's useful as a body of knowledge and not necessarily any one particular piece of knowledge? So this really resonates with us because the functions of my branch try to do a lot of these pieces of support. So we obviously are funding primary research up at the top of the funnel. We have a group inside that does, rapid literature reviews, or this idea of the synopsis, and the process by which they do that was actually established by John, and he continues to come in and do training for anybody who's interested. How do you find research systematically and synthesize it in a meaningful way? And then we're just getting into this world now of the idea, the really useful tool, in Graham's language, it's the guideline or the toolkit, and we have a research evidence tool, for example, that is supposed to accompany every policy submission, and it's a check mark based system that shows which resources you've gone and looked at to support the evidence, to show that you've checked the evidence for supporting the policy development. And then we also have an evaluation unit that supports implementation. They do economic analysis to do costing of options, and they'll do modeling. And so we're supporting this, both the creation of the knowledge and the use of the knowledge. So the best policy development model that I've seen is John Kingdon's multiple streams model, because it's the one that matches the reality that I've seen as in my years as a policymaker for the way things hit the agenda. And for those of you who haven't read it, I will give a shout out to John and his book. Harvey Lazar's the lead author, Paradigm Freeze. They look at a bunch of different jurisdictions across Canada and take about 6 policy reform ideas, wait times and needs-based funding and primary healthcare performance, or look, why did it happen or not in each particular jurisdiction. And they used Kingdon's model combined with the ideas, interests, and institutions framework to really figure out why did these things happen or not. And the reason I like this model the best is it's so fluid and dynamic. Every other model I find quite reductionist and too linear, and this one really talks about, there are all these streams of there are people who are writing reports and are in the system who are shaping the ideas and the discourse, and there are issues of the day that hit the news media or are brought up to a constituency office, and then there's the politics. And this is not necessarily politicians, but it's just the dominant ideologies and values of the system at any particular time. And once in a while they coalesce and the policy window opens. So part of my job is to help you as researchers with good ideas to be alert to when these policy windows open and say, okay, I know that Mike Wilson has a piece of work on multimorbidity. It needs to get into the hands of my colleagues right now. Or the window closes and you have to go on to the next idea. And the health links is, I think, a classic example of where this happened. Ontario moves into a fairly serious deficit position. Health is growing really quickly, and then Walter Wojcik, among others, he's one of the lead authors of this idea of the high-cost users. It hits the desks of a whole bunch of policymakers, and it really seizes their attention. And so you get this, you have people doing the research. It's this issue of high-cost users and out-of-control spending. It becomes the message. And then the dominant politics of the day are such that the community needs more investment, and the community is where a lot of treatment should happen. So there are some people in the system who suggest, well, maybe we need to do this health links approach, and it really becomes a dominant idea. And you can't go very far in conversation without talking about the 5%, the 1%, the high cost user. So it really hit the agenda fast and hard. And I think SARS is another example where I see this happening. So SARS hits and just decimates the entire healthcare system, 10 years ago or so, and so that's the issue. You have to do something, and everybody agrees. And David Naylor comes along, writes a report, says we need an agency, and then window opens and we have Public Health Ontario. And if not for SARS, even Public Health Ontario might not exist today. And they've done a lot of good. But again, the one thing though, this is not a predictive tool by any stretch. It's a tool that lets you look backwards and try to understand what happens. And it's a tool that lets you know that there are windows that open up and you have to be ready. So once the agenda has been set in terms of there's an idea, these are steps that people like myself and my colleagues in the bureaucracy would go through. This is from the ARC website, but it's, Jonathan Lomas and John Lavis and others have created similar versions of this. So in Public Health Ontario, take that example. When it comes to us, it's not more formed necessarily than, we need to have an agency that focuses on public health, or we need a solution for these high complexity users. So, then it's up to the bureaucrats to understand the question, what's the population. It becomes a technical exercise to really take that aspirational idea and start figuring out how to make it happen. So the finding the information, evaluating the evidence are very much in the wheelhouse of researchers. It's about systematically going out, finding the evidence. Is it rigorous? Is it comprehensive? Is it valid? All the things that you're trained in typically in your doctoral studies. And then it moves more into a bit of an art, and this is where researchers typically don't excel, and where the divide between policymakers and researchers is most apparent. So what's the applicability of the evidence? How does this evidence that might have been generated in the US shows a very good effect for a complex population? Is it relevant to Ontario? I mean, maybe it is, maybe it's not. So you go through a series of steps to try and understand, do we have the right human resources to support that option? Do we have the right governance structures to support that option? And how much does the intervention cost? So, that is an omitted part of most research, which is just shocking to most policymakers. Because you ask the researcher, well, okay, that's great. Well, how much is this going to cost? And they say, I don't really know. And well, okay, and then that ends the conversation a lot of the time. You need to have at least the absolute cost, and then hopefully the cost effectiveness. Again, this is the right audience for this kind of conversation. But most articles in JAMA that talk about evidence of effect include no information on cost. This is slowly changing, but it's not something that's conducive to taking that evidence off the shelf. And then, what's the actionability of that information? Can I take that information and translate it into a series of concrete steps? I want to improve diabetes, and I have an article that says, this is going to be a little case study to show you that, audit and feedback work. Well, does it work with the EMRs we have in this province? Can it be paper-based? Will it work with the incentive structure that we have here? These are the translation into the concrete steps. And then finally, is it adequate enough? Do I get a good sense from this evidence what the impact will be? What are the unintended consequences? And again, those are places where, I think the relationship can be very profitable between researchers and policymakers, but it's got to start there, a relationship, so that you can give your opinion, because that's often not going to be anything you can study because it's too multifactorial, but you can provide your opinion, and that opinion is often good enough for us. So my case study, this is the pinnacle of the meta-analysis. It's a really, really well done meta-analysis in one of the top journals in the world. It was funded by the Ontario Ministry of Health, the Alberta government, so there's every reason to think that the results of this should be taken up into the largest jurisdictions in Canada and beyond. And so what they found, and you look at the people on the list who we've got Jeremy Grimshaw and Kavish Sajanya, some leading thinkers in this kind of space, quality improvement. And they found a whole bunch of really effective things. Team changes would improve A1C and promotion of self-management, case management. These are all interventions to employ to improve somebody's A1C level. When Jeremy Grimshaw started to do the rounds with decision makers, they started to ask questions. Okay, well, that's great. How much does this cost? I don't know. Well, what is it going to work in Alberta? We have these integrated clinical networks. How's it going to work in this structure? I have no idea. And he was struck because he couldn't answer any of the policymakers' questions. And to his credit, he's now working on that follow-up study where he's going back to each of these authors and asking a series of questions that will determine the context in which these interventions were delivered and answer those policymakers' questions, because then maybe these will get put into play. Self-management. Was it the Stanford model? Was it this model? Was it that model? So that's the kind of thing. Was it delivered in a system where they really focused on change management and quality improvement? And did they have fee-for-service primary care or not? So these are the kinds of questions that determine context. And roughly, it's in these 4 quadrants, and this is maybe somewhat artificial, but these are some domains in which we would ask questions for that. The art of the applicability of the evidence. What's the financing structure in which that intervention was delivered? What's the governance like? Delivery system design, system characteristics, and these are all things that you're going to know as researchers because you're in that system, but it doesn't end up in the paper, and it's not necessary. I'm not saying it should necessarily, but you should be ready to answer these questions because they're going to be asked if you want the work to be applied. And this is just kind of a visual representation of our branch structure. So we have a research unit. They're the ones who, there are 8 people, and they administer $40 million worth of research, and they run the competitions, they intake the applications, they parse them out to external review panels, and near as I can figure, we do it more efficiently than any other research agency in Canada. 8 people, $40 million. So I'm enormously proud of how lean we can administer $40 million worth of research. The planning unit they're the folks that are doing these rapid literature reviews, and then economic analysis and evaluation is a group of health economists, evaluation experts, and just to show you how the evaluation culture has changed in the ministry, the health links already have a rapid cycle evaluation happening right now, and it's not waiting 2 or 3 years later on, and the typical answer is when you go to a set of people like you, what can you tell me about this? And it's like, well, why didn't you come to me 3 years ago? I could have helped you set something up. So more and more evaluations being embedded at the front end. So there's this culture of the virtuous cycle is starting to take root. So it's something that I think is a huge transformation and gets us closer to that idea of the learning healthcare system where you're looking for gaps, you're trying to do something about it, and then you repeat. So some of the specific strategies we're using to do knowledge translation, there's some externally facing activities and internally facing. So, the idea of the knowledge translation effectiveness is an honest two-way exchange. So we invite people we fund and people that are working on things of interest to come and do these research and policy dialogues. I say two-way knowledge exchange. It's a fairly typical didactic type structure, but there is a chance for exchange throughout. But it lets the researcher be known to a group of people. So I think it's the starting point. And we're starting to develop what we're calling these policy roundtables with very interested set of our colleagues in other ministries as well, maybe, and have a facilitated session where the exchange can start happening in a more two-way format. And then probably the most effective method of knowledge exchange happens with our applied health research questions. So everybody we fund, we ask that they set aside 25% of their funding to respond to questions coming from users from the field. This can be a hospital executive, somebody from the ministry, and a nonprofit organization. And there the knowledge user reaches out to the individual researcher and have this idea, and then the exchange happens. Well, here's what you could do right off the bat. We actually have that data maybe, or I don't, and I'll actually have to do a research project, and here's how the idea gets formed into a question, and they get to move forward together through that co-production of research findings, and then the user's hopefully more invested in using the results, engaged from the front end, and the researcher comes to understand the dynamics of the user a little better. So those are some specific tactics we're using. And then again, I've already talked about this, but internally facing activities are production of literature reviews and the evaluation activities. The literature reviews at the front end, and then evaluation to support implementation. This still happens where I've had a couple calls just in the last couple of days where my colleagues will get in touch with me because a researcher has called them and said, I need a letter of support, I need it in 2 days because my grant's due. And to me, that's a failure of the researcher to understand that knowledge exchange has to be based on, at first, respect, because if you want this knowledge user to be engaged, asking them to produce a letter in 2 days is not a good start, and it leaves a bad taste in the mouths of the policymakers. So I'm building that into all my outreach activities. At the very least, get to the policymaker with 2 weeks, and then even more so, let them be involved, because there are some really interested policymakers out there. Not all of them will be, but they might want to see your proposal, and it will probably end up more relevant after they've seen it and made some suggestions. And if you're ever looking for who to get to for the right signature, I'm always happy to offer that role. I can help you find the right policymaker for your project. So, these are some of the emerging research areas that I'm seeing that need good science behind them. And obviously, the very mandate of CHEPA is such that it's well positioned to deliver on a lot of these themes. These lines are, again, probably somewhat arbitrary, but I had to connect each one to something. And I also wanted to use this slide as an opportunity just to try and understand from you, as a group of people who are producing knowledge. You saw the 12 priorities and these themes here. Where do you think the province should be investing in terms of emerging science to support what we need to do in the next 10 years? And I just was hoping to hear some thoughts from the group, because I'm getting close to the end here. And since you're all in the midst of it and we don't have the answers, I'd love to hear from you as a group. Well, the question is, what do we need to be investing in, collectively, not necessarily the province specifically, to ensure we have the right information to tackle the next set of challenges? I mean, these are the challenges that are on the agenda right now, and we're answering them in a particular way, but they're also the challenges that we don't know about that you're working on. So I just want to know, what would you think is a key challenge that needs better evidence, better tools? Yeah, please.
Data accessibility is a daily problem for us. I don't know about anybody else in the room, and linking data, huge huge issue for us.
Tell me more.
We've been trying to do a study, we wanna look at cancer survivors and how their
Childhood cancer.
childhood and how they perform on educational tests. You think very simple linkage,
Mm.
right? EQAO database to CCO or POGANAs. Can't, like, it's so brutal, you end up talking to lawyers forever because the privacy issues, and they're like, well, we can't link that to that because it's not health data.
Well,
So
and it's
the
governed by different legislation,
Yeah.
and, you know, health data has that stipulation around, you don't need to get consent if it's, you know, for certain purposes under PHEPA. Our Chief Medical Officer of Health is launching Panorama. It's a vaccination surveillance tool. And they, I think, have made a big leap forward because they actually got access to the Ontario Education Number, which allows them to create a, you know, basically that yellow card that you all know about when you get your vaccinations, but electronically, because we know who we vaccinate and we know who the students are. But they were, you know, it did require a lot of work to get those things together. The mental health and addiction strategy, I think, has set the stage for that because there are something like 13 ministries involved in that: children youth services, education, community social services. So I think, and the Health Links is also a big driver of data integration because everybody's quickly discovering it's not so much the health care that's going to drive the success of somebody. It's whether they have housing and whether they have income support. And so I think in the next 5 years, at least, I'm hopeful that some of those things will start to be tackled because all these people will be together and they're going to want to know those things themselves. So that's not so much something you fund as, oops, that worked there. Fund as research, though. I mean, that's like that's an infrastructure issue, though.
But it prevents us doing a lot of good work. People are really interested in the work we're doing. Gee, it would be really good to see what programs could we put in for cancer survivors to help young people achieve in their lives as opposed to becoming burdens on society.
Yeah.
And we can't do it because EQA won't play.
Yeah.
What can the government do to help with that? I guess is the
Well, I think,
question.
you know, I think we end up trying to take a leadership role as the Minister of Health because we're probably the furthest along as a government ministry in terms of using data and trying to break down some of those. You know, it's not like the Health Links analogy. A lot of what Health Links try to do are bring together partners who are all trying to do roughly the same thing but have never worked together, so they have no history of collaboration. So, you know, part of my effort, I think, will be to start building some of those bridges.
That would be helpful.
Yeah, I think it's critical. I couldn't agree more. I really couldn't. I mean, education alone linking would be enormously powerful. And then you start building in children youth services and community social services. You get developmental services data in there. You know, as a government that funds these services, it I think is important for us to understand how these things all fit together and work together. So, I agree. This is your chance. I mean, we create the priorities here, so and we're lucky in that we have a fair amount of autonomy in setting the priorities. So, yeah, please.
So I know there's a Health Human Resources Strategy Division in the ministry, but how does that type of research, which I think is directly related to a lot of the 12 themes, how does that get funded if it's not a theme in itself?
Yeah, I mean the most applicable one is the nursing stream, and it's I mean that's just one piece of HHR, but I think you just need to pick a category. I mean, if it's, you know, let's say you're interested in PSWs, you know, the community-based care priority is probably a good fit. And, you know, the 12 priorities are encompassing enough that I think you can fit your
So
HHR.
whatever your HHR is within, pick one of those, okay.
Yeah, you know, it's always tough to pick a category, but you know, there is no HHR one specifically. And they do a lot of their own modeling work, and the other thing to remember about research funding is that we're not the only stop. I mean, a lot of branches will commission their own research, either, you know, through a consulting firm or directly with, you know, with an academic like yourselves.
I mean, a similar theme in that, I know for some of the work we were doing, these more generic functions, I mean, I know you had funding up there, but like in the 12 priorities, funding per se wasn't kind of a category, you had to kind of fit it.
Yeah.
And so that there are a number of these kind of, whether it's financing or funding or some of these more generic kind of categories that are quite foundational and the work can apply in a number of these different areas. The current structure it was hard to think outside of, as you say, trying to categorize it some way, one of them. Anyway, just reflecting on our experience of developing the proposal in the current structure, I think that was something that struck us is hard. If you didn't work in a specific category that was listed, again, it's more basic, kind of just generically funding, financing,
Yeah.
HR was hard. It's hard to fit.
I think financing reform is one area that needs clear capacity development, because you think of I think across the country, of the people who, you know, are real experts in that, and you probably don't get beyond a few hands worth, I would say, whereas you look at clinical effectiveness research, and there are, you know, hundreds and hundreds and hundreds of people who are very good at that, but, you know, people who can help you figure out what's the episode of care, what's it going to cost, what are the best practices, because it integrates health economics and clinical effectiveness and implementation science. So I think that's one clear area where we need more people helping us figure that out, and the folks in the US, I think, are probably a little bit ahead, but not necessarily that much further ahead. Yeah, please.
Similar to Jerry's, I was actually going to say something very similar, but also add in understanding the best forms of governance for health systems as well. So that's something, you know, the list is so heavily focused on delivery stuff, that, you know, I think Jerry's point was something I was going to raise as well, and I'm saying as well, on top of that, you know, decentralization versus centralization, those types of things, you know, what's the optimal type of board structure for public hospitals, like those types of things, don't seem to feature and the methods right now that I know of for evaluating those types of things are, in early days, it's tough to do, and you can't get a what works effectiveness randomized controlled trial for a lot of those types of questions. So I think more money needs to be invested in supporting people to develop those capacities, so that, you know, 20 years from now we can actually have a systematic review of centralization. You know, I don't know what that looks like right now, but kind of looking ahead. And then as well, kind of also, a lot of the implementation science work is focused on the clinical questions, so how to change physician behavior or provider behavior. Where a lot of the work, you know, this is actually just you say this is our chance where I'm promoting. The thing I'm interested in is, you know, how do we understand implementation of research evidence at the health system level as well, in the policy making process. So huge weight put onto providers and changing their behaviors, not as much development in the, you know, how do we incentivize policymakers, or how do we put structures in place that facilitate knowledge translation at that level. So those two areas.
Yeah, they're all fair comments, and a lot of what will drive the implementation science are not the classic, you know, delivery design type studies, and they're starting to move more into the bailiwick of business schools, and because it's organizational capacity and development and governance, and not something that most, you know, classically funded health services researchers know anything about. But it's going to be the only way that a lot of their ideas get into practice, is by focusing on those, you know, levers of change, you know, behavior being one of them, but not the only one. This is my last slide, and again, I just leave it here because this is the purpose of the research fund, is to create this virtuous cycle of finding issues that need to be addressed and generating evidence around them and supporting the evidence that emerges to get into practice. So I'm always happy to have a conversation with any of you about your ideas, how to support your work, whether we fund it or not, in getting into practice. And that can take the form of brokering relationships or just quick advice on how to format something most effectively. And please feel free to take me up on it. And because we got a lot of challenges, and this is one of the ministry's major mechanisms to try and make sure that we have the right people and information to tackle those challenges. So, thank you for your attention.
Do people have more general questions or comments coming out of Michael's presentation?
Yeah, thank you. Just to follow up on the story about Jeremy Grimshaw and looking at the questions he was not able to answer. I was wondering to what extent are you finding those types of research which will provide information?
I'm sorry, to what extent? I didn't...
You know, Jeremy Grimshaw and team had this
Yep.
very nice review about
Mhm.
effects of different
Yep.
diabetes. And when it came to the policymakers, there are those questions
Right.
which he didn't have answers to. So I was wondering to what extent are you finding those types of research which would provide answers to those questions?
Oh, yeah, it's not very often. I
So
mean,
would that then be a focus of your?
well, that's, of the people and projects we fund, explicitly a focus. I mean, we're I mean, there are, of the 11 we have, just using John and Jerry because they're here, they don't really need much support in developing a KT plan because between the two of them, they have been doing it effectively and have contributed to that literature themselves, all the way to the other end of the spectrum where we need to be a lot more hands-on and helping the individual craft that plan. And inherent in the projects we fund, because we do it in a two-step process, there's a group of internal ministry folks that does a policy relevance review. So inherently the topic is going to be relevant to somebody in the ministry, and then the merit review. So that is an important distinction between how we fund versus how CIHR and other granting agency would fund. It has to get through that policy relevance filter first. So through those mechanisms, we try to make sure that at least the people we fund are starting to answer that. Otherwise, we just do it ourselves, and using, kind of try to be as explicit as possible using steps, but often it comes down to a bit of a gestalt assessment of how that evidence is applicable. Japan spends less than we do. Why is that? I mean, is it a social structure issue? Is it a demographic issue? Is it something about the way they have specialists and the way they organize their hospitals? That never comes through. It's you just see kind of a number or an effect size or those wraparound things. Frequently, we just end up having to do that assessment ourselves.
It looks like a big piece of information. It's
Well,
very important because according to the story you gave, the conversation with Jeremy stopped somewhere because he couldn't
Exactly.
provide that kind
Yeah,
of.
and I think it's that contextual piece that's missing, and just knowing a little bit about what Jeremy's trying to do is then how do you build that up so that it becomes less generic and more specific and more useful to the policymaker.
I had a sense in that part of your talk that you could almost roll off a set of 6 questions or something that will be asked. And I realize there'll be variations across the studies, but I mean, I'd be curious if you could generate a list of those 6 questions that, as a researcher, if you're going to engage with a policymaker, you should have answers to the following questions.
Yeah.
If you want to be listened to at all. I don't know if it's possible for you to, I don't know,
Well,
you can finish follow up with just a bullet point. Here are the 6 things that you think,
The
as a researcher trying to engage in owl translation.
cost would be one of them. and not just the incremental cost, but the actual cost of the intervention. You know, the kinds of professionals needed to, you know, this is, you get this tail wagging the dog phenomenon sometimes where, not to pick on cardiologists, but cardiologists are a very well organized research machine internationally. So they have a lot of evidence to support, you know, cardiology-driven interventions, but, you know, we don't have all the cardiologists in the world. That's not necessarily what you would want to do on a population health perspective. So, you know, you don't necessarily want the effect size driving what's not right for the HHR plan of the province. So, you know, I think it's just some of those, you know, it's not just the evidence, so it's the cost. You know, will it fit into the dominant structures that exist? Like we have LINs, and will it work with the way they fund things? So those are just very quick ones, but cost is right up there. Yeah.
Is there capacity in the evaluation unit in the branch to undertake those types of cost-effectiveness analysis once someone like Jeremy does the due diligence to do a great systematic review like that? Because sometimes I don't think it's within the remit of the proposal or their their funding stream to do a cost-effectiveness analysis.
No, but they can at least do. I mean, if you don't know absolute cost, then there's a problem. I mean,
Yeah, I guess my problem is that like a systematic review is like global evidence, right? So you're getting stuff from everywhere, and then cost is so contextual.
all those, well, it's better than nothing though. Like, and sure, cost is contextual, but none of those studies that went into the systematic review, you know, save for maybe a handful, would have had the cost of their intervention, and they would have had to have known because they would have had to pay the people. Anyways, it's a pet peeve of mine that it gets omitted so often, and there is the capacity, but the problem is they are doing so much. Like we have several PhD health economists who are quite capable of doing a cost-effectiveness analysis, but they're just too many things on the go for them to focus on that one particular project. We'd more likely put it out through an ARC process and ask one of our funded researchers to do it if it was really important to us.
Right. Well,
Or they would do a less precise one that would be good enough for decision-making purposes, but might not, you know, pass muster at an editorial board. So, but I hear you. I just think as we move forward, you know, getting evidence to be more rapidly applicable, that's one big area that could advance the uptake.
So two questions, both kind of have to do with making a good system work even better. So the first has to do with the competition, which I think was remarkably transparent and had a huge number of advantages to it. So I mean, it was very difficult for the transition period, and remains difficult for centers like CHEPA, but I think there are many aspects of where the health system health system research fund competition was structured that were great. Two things that strike me looking back. One is a seeming emphasis on kind of individual and group capacity development over institution and system-wide capacity development. And if you look at the Alliance for Health Policy and Systems Research did one of their flagship reports on capacity development, and really said, we need to be building institutions and the broader systems where those institutions are collaborating rather than focusing on individuals and subgroups. So there's a little bit of a tension in the new program that it's the folks who happen to be in a small group and then the students and so on around them that are upping their game. But I guess the nice thing is that although it's kind of extra work, the SPORE kind of initiative that's linking the Health System Research Fund group does have the potential to up the game for a variety of folks. It's just something to think about in the next round about can there be some attention given back to the idea of the institutional stuff. I don't know how to do it, but it's just one thought. The other thing is just around the transparency. There were so many aspects of it that were very transparent, but then as you said, there were the kind of grandfathered groups, and for them I would guess that in the long run it's not advantageous to be always given a pass in these things. So I think, I would think that they would want in the long run some very transparent process of periodic review that everyone feels is very defensible. If they are kind of too big to fail, then they at least need to be assessed periodically. It just for kind of equivalence. And then the other point has to do with I've lost my train of thought about the third one. It was about that it seems like we went through kind of a golden age, in Ontario, which had been quite kind of backwards in how it was using evidence, at least from the outside. And then all of a sudden, all these innovations, so you have the excellent Care for All Act that enshrines in legislation the need to use evidence. You have the research evidence tool. You have strong signals from the top. You have performance requirements. You have the training on offer. Many, many things. And every once in a while, I hear people say all of that is seemingly starting to ebb a little bit. Now, clearly, the legislation is still in place. Research evidence tool is still there. But how can we make sure that this isn't just another trend in the system? Is there a need for another jolt to the system that kind of keeps up the focus? And in the words of Mirtha Rosas, the head of PAHO, she always says we need to protect the gains and fill the gaps. So how do we protect those gains and not make it conditional on certain people in high-placed positions keeping up the pressure, but it just becomes the way that Ontario does business, and they're constantly looking for ways to do better.
Yeah, I mean, I wonder if some of the ebbing is just, the part of the cycle we're in right now. I mean, there aren't as many policy submissions going forward. Hopefully it's more related to that secular trend than anything related to the use of evidence. But I couldn't agree more. We internally, I think, have a series of things we're trying to do. We're going to look at the research evidence tool, for example, because we've had some experience with it now, and can it be made more useful? We have a new assistant deputy minister coming. She's just been on at the desk for a couple months now, and she's coming from cabinet office. So we're going to use her experience, because she was really the air traffic controller for all the health and social policy submissions coming forward. So I think she'll have some good insight how to ensure that that the baseline is that you're using evidence, and just the fact that we're here and we're funding and we're drumming up business, I think is a huge piece of that puzzle. But it's easy to as a policy developer to get into your work and look at what you can look at, but I think it's just it's a marketing effort on our part, and it's us giving them tools that are really easy, and that's why we fill out that research evidence tool for people and we send them literature reviews, so we should try to make it easy. But again, we're always open to suggestions if you've seen things that have worked out in other jurisdictions or have ideas. Fire them off to me.
And on the first point about the transparency and the institutional capacity strengthening, when do you restart the conversation about what the next competition would look like? It probably isn't far off. It's probably sometime in the next year, right?
Well, exactly.
Yeah.
The program awards, year in, but we'll, realistically, it's about, we start planning about 16 months from start of the next one, which means it's only about 8 months away from that. So pretty soon, I would say sometime in the fall. The other piece of the puzzle that I forgot to mention is that last year, or for the FISI grants, the Population Health System Improvement Grants, we, for the first time ever, agreed to cash match. We'd always done the in-kind matching, which you, as a partner, you need to find a partner who would put forth, I think it's 20% or up to 20%. And we'd always just done in kind through our own time and resources. But this year we actually said to 20 applicants, we'll actually give you the cash match should you be successful. And we're hoping to be able to continue that. I can't make any guarantees, but it's one of the CHR competitions that's really relevant to decision makers, because incumbent on the researcher is going out and finding that partner who then has to put some money up, and then hopefully that money on the table really weds them to the project and using whatever comes out of it to improve policy and health.
Okay, it's now 1:30, so we're gonna have to wrap up.
Okay.
So just join me again in thanking Michael for